So if I could ask members of the board, new and returning, to take a seat, we're going to get started in a moment. All right, members of the board, welcome. Welcome to meeting 3, but for many of our new board members, meeting 1 for you. So welcome to meeting 3 of the Board of Health for this term. Welcome to members of the board, to other members of council, and to members of the public. For those who are following, you can follow the agenda and debate on your computer, your tablet, or your smartphone at www.toronto.ca/council. And we should begin, as we always do, where the Board of Health acknowledges the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. For some of you, this is your first board meeting, so thank you. Do not be intimidated. Yell, scream, interject. No. Interject is fine. Those were directions to Councillor Perks, but nobody else. But really, this is the first meeting. It can seem very official. If you have any questions at all, don't hesitate to come on over directly to me or to put up your hand and ask a question. We're here to help. We're going to start by running through the agenda. So that is the yellow sheets in front of you for new board members. And we're going to go one by one to see which is held. We have on item 3.1, actually, before we run through that, are there any declarations of interest under the Municipal Conflict of Interest Act? Seeing none. All right, I need a formal confirmation of the minutes from January the 30th, moved by Councillor Perks. All those in favor, opposed, if any, carried. Agenda item 3.1, the Toronto Indigenous Overdose Strategy. We have deputants on that, so that is held down. Agenda item 3.2, expanding opioid substitution treatment. We have deputants on that. For new members of the board, your green sheet has the list of deputants, I should note. Item 3.3, addition of edibles and other products to federal cannabis legislation. Is there anybody who would like to hold that down? I was about to say MPP Wong. Sue Wong would like to hold that down. That is held. Item 3.4, Board of Health Committee and appointments. I will hold that down as we need motions. Item 3.5, Heat Relief Services update. That is being held. Councillor Perks. Item 3.6, introduction and enactment of bills. Is there anybody to hold this down? Don't? All right. Can I have somebody move the bills? I will. Councillor Lai. All those in favor, opposed, if any, carried. Item 3.7, need for more affordable, supportive, and harm reduction housing. Moved by Councillor Perks. All those in favor, opposed, if any, carried. Okay, that brings us to the start of our list. Item 3.1, the Toronto Indigenous Overdose Strategy. To our Medical Officer of Health, do we have a brief presentation before deputants on this?
So we were in fact, thank you Mr. Chair, we were in fact to have a presentation by our facilitator, Michelle Sue, who was instrumental in the development of the Toronto Indigenous Overdose Strategy. Unfortunately, she resides in a part of the province that seems to have suffered more significantly from the weather of the last 24 hours and was unable to join us today. But by way of introductory remarks, which I'll make a few comments in respect of the strategy, and then perhaps turn it over to my colleague Susan Shepherd, who's just sitting over to my right and in front of me a little bit to make further comments. Then perhaps we can move to the rest of the agenda. But just for the benefit of those around the room, particularly those members of the Board of Health who are new to the table, there is a Toronto Overdose Action Plan that was approved by the board in March of 2017. And one of the key recommendations that came out of that plan was for there to be a Toronto Indigenous Overdose Strategy unique to the needs and to the circumstances of those who are members of our Indigenous communities in this city, and that the strategy was to be developed led by an Indigenous facilitator, so that it is for the Indigenous communities and by the Indigenous communities. So we have successfully managed to see our way through that process, which is why you have a report in front of you. I think I would be remiss if I did not comment on the fact that the facilitator, Michelle Sue, who helped us and helped to organize the meetings with various members of the community, which I suspect you'll hear about from my colleague Susan Shepherd in just a few moments. Michelle Sue's ability to provide facilitation for this process was funded by our colleagues at the Toronto Central LIN, and I just wanted to acknowledge that. So with that, that's a very high-level summary, at least context setting, in respect of how we came to this point. And just to give you a little further by way of high-level detail, I'm going to turn it over to my colleague, Susan Shepherd.
Thanks, Dr. Davila. And it is unfortunate that Michelle Sue could not be with us, because I think very much this report that she developed is her voice and represents what she heard as she met with folks in the community, which is really what this is all about. And I think that key to this report is that it really reflects the voices of people who use or have used drugs in our community. And she met with several advice circles ranging from that involved a number of different groups, and she used that advice on top of some feedback that she got from service providers, both Indigenous and non-Indigenous service providers who work with Indigenous people, in a session that was held with them. So it was that combination of the advice circles, of people with lived experience and service provider input, that led to the recommendations that you see before you in this report. And I think that the report really reflects the profound impact this crisis is having on the Indigenous community. I'm sure you'll hear more about that in the deputations. And certainly we heard a lot about the trauma and grief that people are experiencing in their lives, and the ongoing impact of colonialism and racism, and how that impacts people's quality of life and their ability to access services in this community. I think that the recommendations are comprehensive. They reflect prevention, harm reduction, and treatment kinds of initiatives, and are directed at all orders of government, including the Toronto Public Health at the City of Toronto. For me, I think the biggest message to come out of this report was that people want Indigenous services delivered by Indigenous service providers, in particular people with lived experience. And that was really the overall tone, a message that I think came out of the report. The recommendations align with those in the Toronto Overdose Action Plan, which has already been endorsed by the Board of Health, and we're in the process of actually refreshing and updating that strategy, as well as the Toronto Indigenous Health Strategy that Toronto Public Health is supporting. In terms of next steps, Toronto Public Health is committed to helping to support implementation of this strategy. This is a community strategy. This is not our strategy. We don't have ownership of it, but we want to be walk with the community and support the community to implement the recommendations. We are going to dedicate an Indigenous staff person to help with that coordination and to work with Indigenous service providers and the community on this work. And we will implement the recommendations directed to Toronto Public Health, and we'll report back to the Board of Health in a year's time as to the progress that's been achieved.
I can't thank you, Susan. I just want to reiterate our strong commitment at Toronto Public Health to this strategy as a part of our overdose action plan writ large. And I'll turn it back over to you, Mr. Chair.
Great. Well, thank you, Susan and Eileen. And for new members of the board, the order in which we will structure this, we hear from deputants first, then there is an opportunity for questions of staff who are here, and then we move into speakers. So that is the structure and the order in which we'll always follow. We have a series of deputants, and so I would ask that our first deputant, Steve Teekins from Name-Res, Native Men's Residents, come forward. Steve, you've been here before, but you have a clock to my right there, and you'll have 5 minutes when you're ready, and we'll turn it over to you. Thank you, Steve.
Okay. Bonjour, Josh Gauger, Jiwang Nabe, Manadona Ne, Disna Kaz, Web She Do Dem, Nipasing Dunch. I just said a salutation in Ojibwe language. I'd like to let you know this is International Year of Indigenous Languages, but I'll speak in English. Anyways, I'm the Executive Director at NAMIRES, Native Men's Residence. Indigenous-run organization with an Indigenous Board of Directors, Indigenous staff, and we've been around for about 33 years. We operate a menu of services for homeless Indigenous men. And, it's well documented, and it's mentioned in the report throughout that Indigenous people in Canada have poorer health on average than non-Indigenous people. Both measures of health and well-being, Indigenous people comprising of First Nations, Métis, and Inuit people in Canada also carry a disproportionate burden of the harms related to substance use. The Toronto Indigenous Overdose Prevention Strategy Summary Report clearly demonstrates that there's a need for tailored services and policies that are better able to meet the needs of Indigenous people in Toronto. The health inequities experienced by Indigenous people represent structural and systemic disadvantages that result in the enduring legacy of colonization, which has served to displace Indigenous people. Connections to Indigenous culture has shown to play a role in reducing disparities in health, including substance-related harms. The further development of culturally based Indigenous, governed, and operated community services holds promise for achieving gains in population health and reducing disparities among Indigenous people. For the last two street needs assessments that the City of Toronto conducted, it clearly demonstrates that the Indigenous homeless population is predominantly male. In 2018, the number was 64% of all the Indigenous respondents were male. In 2013, the Indigenous male respondents was 72%. That's staggering numbers. We at NAMIRES, all of our programs and services are culturally based. We have a wide array of programs and services that reflect the diversity of Indigenous cultures in this country. Often people mistakenly think that there's one Indigenous culture. Well, that's not true. That would be like me saying, all the Irish and Scottish people are all the same. I know some people might take offense to that, but that's not the case. Indigenous people are diverse as this country is from coast to coast to coast. So NAMIRES is interested in expanding its current spectrum of services to include harm reduction shelter program. Primarily, there's a significant service gap for Indigenous men that are chronic substance users in the community. Active substance users are significantly limited in their ability to access service in the Indigenous community, including shelter beds. Our organization has seen many community members who are living on the streets struggle with addictions pass away. And often their deaths are a result of accumulation of unhealthy lifestyles as well as lack of shelter. NAMIRES has had in our strategic plan for the last 10 years to operate a harm reduction shelter to serve this population. I know we're in the midst now of Toronto opening up 1,000 shelter beds. I strongly urge our officials from Shelter Support Housing Administration to let the next shelter be an Indigenous one. The one that's harm reduction. It might possibly save lives. We have a model in place. We submitted and participated in various research projects. I think we're now on our 5th one. And just like the Toronto Indigenous Overdose Prevention Strategy recommends an Indigenous-run harm reduction shelter, I urge you to please get this up and running. That should be the #1 priority for the next round of shelters. In closing, I would like to mention that this is a day and age of reconciliation with Indigenous people. Our homeless Indigenous people are often those most adversely affected at the bottom end of the social determinants of health. In the name of reconciliation, I strongly urge the City of Toronto to step up to be leaders in addressing the disparities among homeless people in our city through the creation of policies and opportunities for the provision of Indigenous governed and operated services to address the prevention of Indigenous overdoses. Now, time is of the essence. I know when we were trying to get a framework for our new shelter, we invited experts from all across Canada. This was 10 years ago. We've had so many deaths take place since then. We need to get these things up and running now and save lives. Anyways, miigwech.
Miigwech, Steve. Are there any questions for Steve? Seeing none. Thank you, Steve. Our next speaker, Bear Charles could not be here, so our next speaker is Bradley Nolan. Is Bradley here? Great.
Bradley's not here either, but he did bring this statement to be read, so I think it's important that's read aloud.
Absolutely.
Not just submitted.
And thank you. And your name is?
My name is Walking Wolf, a placement student in Counterfeit and Keepsakes Overdose Prevention Site through South Riverdale Health. I'm a frontline worker for a long time, not paid, but under the great law in this area, doing First Nations, Métis, Inuit, urban, street outreach and street patrol under the great law. And we did that ourselves because we saw what was happening on the streets. We didn't get paid for that, we just did that. And Allen Garden's food and clothing outreach, which I'm sure a lot of you here are probably aware of too. Okay. This piece is very personal, so I wish he was here to say this in his voice. Just keeping that in mind. So it starts as such. Hello, I am here to speak to Toronto Indigenous Overdose Strategy. Thank you for this opportunity. I'm also here to speak on behalf of the many Indigenous people who access the Moss Park Overdose Prevention Site, and to speak on behalf of my loved ones who have overdosed and died. I've lost my best friend, brother, and my first love who overdosed and died at the beginning of January. He was also homeless. My name is Bradley. I'm Two-Spirit Ojibwe man from Garden River First Nation. I'm physically dependent to opiates. I've overdosed about 4 times. 2 of the times I've overdosed and came on my own, I'm lucky to be alive. I never overdosed before until I started using fentanyl, which is basically all that's around. My tolerance is so high, that's the only thing that makes me unsick. I've been on Suboxone. A lot of traumatic things happened to me, and so I started using again. I tried getting better by moving back to my res, but I was forced back to using because clinics wouldn't give me medication. I tried to take Suboxone again, and so I started using again. I used drugs because of intergenerational trauma, being homeless because of homophobia, not wanting to deal with and feel the things that affect Indigenous people because of colonization and historical trauma we have faced. I used because of all the losses and all the people who have died in my life. And it sucks using the drug that killed my loved ones, but it's all there is. The service I utilize and frequent also am employed at Moss Park Overdose Prevention Site. I work as an outreach peer worker doing Indigenous outreach and Ontario HIV/AIDS Aboriginal Strategy OHAS. And as far as for this Indigenous overdose strategy, it is good read and good to see on paper, but actions speak louder than words. I'm wondering as to when some of these ideas, plans, and strategies are going to come into play for real. This overdose crisis has been going on for years, and it really sucks to see it's taken this long for you to acknowledge on paper its impact on us, Indigenous people. The overdose emergency is severely affecting our people and our youth. I lost my first love at the beginning of January while you were writing this whole strategy how many Indigenous people, like my first love, overdosed and died. My best friend, she died when you were starting your consultations. We need low barrier, open-minded, culturally based spaces that are community-minded, like the overdose prevention site at Moss Park. We want the city to continue to support these as they are needed throughout. Two-spirit people are particularly neglected and overlooked. We need to be included. We need our own services for and by our people, our own shelters, our own safe spaces that include overdose prevention sites, drop-ins, housing, and employment centers. Poverty impacts us. In your report, you said 90% of us are living in poverty. Pierre overdosed and died 2 years ago after being turned away from a respite center. Indigenous people are still turned away as the shelters and respites and drop-ins are full. But we also need housing, and in this report, it doesn't say anything about immediate shelter and housing. Native people shouldn't be homeless. We shouldn't be in shelters, particularly in our own territories on our own lands. This is our home, and we should have priority for housing. Reconciliation needs to include housing. The city has a responsibility to us. We are some of the most criminalized for drugs. We fill the prisons and jails. Drugs should be decriminalized. The drug war is an extension of colonization, and we need access to safe supply and opiates. We need access to elders, to Indigenous counselors who are open-minded, who would work with Indigenous people who are using, who wouldn't judge or exclude us, who believe in harm reduction. We need access to dealing with our grief and our loss. We need our healing circles and ceremonies. This is an emergency. We are used to your reports. They have no action. It's all just talk. So while you adopt this, what is the action of the city? This is making a lot of demands of the provincial and federal governments, but you have a responsibility to us. You are on Native land. So thank you for allowing me to read that.
And I'm just going to ask you to wrap up as we're already over 6 minutes, if you don't.
Yeah, thank you for allowing me to read that. That's all. Thank you.
Thank you very much. Miigwech. Just before you leave, I know you were reading that on behalf of Bradley. Are there any questions from members of the board? Thank you very much, Miigwech. All right. Our next speaker is Ian Kopgog. Ian is not here, I understand. Our next speaker we have is Zoe Dodd. Oh, you're not speaking? Okay. And so our next speaker is Les Harper. Les.
I'd like to say, Danse, my name is Les Harper. I'm originally from Saddle Lake, Alberta, but I grew up in Toronto most of my life and in the Indigenous community. And I work at South Riverdale Community Health Center at the Safe Consumption Site and the OPS here in Toronto. And I'd just like to say that I think it's great that there is a report done, and there's many great things that are in this report that are put in there. But it's something that is long overdue, that we've needed this a long time before. There's many people who have died in an Indigenous community that are not being acknowledged. And that's something that we need to be doing sooner than later, and not waiting for these people, more people to die, because that's happened on such a great rate that we can't even count that right now. We don't even know that in our own communities that we see that. Most of our communities are abstinence-based organizations that don't allow our own people to be serviced in those organizations. And I think it's great to have people be able to speak on our behalf in this time. Where I thank Steve Teekins and Walking Wolf to be here to speak on the behalf of our people and the people that will be after me to be able to speak on our behalf. That's one of the things that is really important with this report. It's great that there was consultation with Indigenous people with circles, but the process of it, I have issues with that there were circles that were created for the different groups and different people, but how was that process done? There were circles done, then there was a report done, and then some people got asked for the input back, but by email. Most of the people that are directly involved with this will not be answering emails, will not be answering messages this way. And if we're truly using a traditional way of looking at this report, you would have a circle, and then you would have people do that report, then come back and have circles again to talk to those people, to see if you actually get the voice heard, because that's a colonial attitude that has always been done. Is that you hear something from us, you take it from us, and then you put it into your words, how you see what you thought you heard from us. And that's something that I find really offensive, that I think that needs to be looked at, and looked at in a way that we need to hear from ourselves. There needs to be more Indigenous drug users' voices need to be heard. That is the thing that it was not really heard in this. And in the advisory, we had people that are abstinence-based and Aboriginal people, which are great. We need abstinence-based programs in the Indigenous community. They're so important. There's a lot of great programs in this Toronto. But we also need Indigenous programs that are harm reduction based. And we don't have that now. We have very few things that we have. We have the Nietzsche Circle in Allen Gardens that is abstinence-based, that people are allowed to go to, that are using in circles. But most programs in the Indigenous city here do not allow people to be around culturally activities. And so how are we going to be able to fix those things? How are we able to go into a place of reconciliation if those people are not even allowed into those doors? And that is the thing that the city needs to work on, to create those programs so we are able to have our people to access those things. Right now, Indigenous people that are using drugs that are out are not able to use those places because they're in their outlook, are not able to, don't fit the criteria of those programs. And so we need to have those more. And that's something that I think that is really important. And we need to ask these questions, and how do we find those things? And how do we bring ourselves to able to have those places for ourselves? So one of the things I believe that we need is have Indigenous-led programming. Why wasn't this more Indigenous-led? There was Indigenous people that were led. The person that wrote this is not even here. And I think that's something great that we need to have those voices here as much as possible. And we don't have that many people here that are Indigenous that are going to be speaking. I can see that across this room. And why cannot the city have a way to bring that more forward? And that's something that I believe is so greatly needed. And that's something that, in Indigenous society here, that we're looked at as people that we are not even able to talk to our own community. And so how do we even expect that the city is going to be able to speak to us? And this is the first time we've lost so many people. I've lost so many relatives have died of overdoses in the short time that this report is gone. I've lost people that I've worked for in this community. I've lost friends in this time continuously. And it is not looked at. There's no inquest on these overdoses that have happened in Toronto of people that have died that are Indigenous. But we see people that that are non-Indigenous have a lot of media outlook on that. When we need that more on our own people, and that we need to have that space, and we need people to step aside to let us do those things that help ourselves run those programs and those things that we need. So I'd like to say miigwech, and thank you for listening.
Thank you, Les. Questions from members of the Board of Health? I have a question, if it's all right. Yeah. In some of the recommendations, specifically around on the treatment side, there's recommendations around harm reduction and specific consumption sites, Indigenous consumption sites. On the treatment side, one of the recommendations is around culturally specific treatment around medical clearing, including more traditional approaches, wellness circles.
Yes.
For my own learning, and you're on the front lines, what would some of those treatment approaches look like?
What are the things that will reflect? So one of the things that, like I said, like we need to have places that are in treatment-based places that accept people that are using drugs, using opiates, using alcohol, and not have, most of these programs you have to be, you have a certain time to be not using drugs or alcohol. And that's something that we need to find that space. How are you able to participate in something that you're not even be able to walk into that door? And that's the thing that we need more of programming there. And that's great, some of the things like Steve was saying that they're trying to create and try to and do. And the Native community has been doing that, but we just need more space for that, and we need the city to help provide that for us. And I think it's great that people have tried to make this report to do that, but there's a lot of things that I believe that need to be done a lot more and a lot faster, because this is a crisis that we are in, and it's never been acknowledged of how greatly this crisis is and what has happened compared to many of the other crises that have happened over the years in Canada.
And a follow-up question. So you work at the South Riverdale Community Health Center?
Yes.
And so South Riverdale operates one of the supervised injection services.
Yeah.
One of the key pieces of feedback and recommendations in here is to see in Toronto the development of a supervised consumption site, an Indigenous supervised consumption site.
Yes.
So from your experience working at South Riverdale, do you see the necessity for that Indigenous supervised consumption?
100%. I work at South Riverdale Community Consumption Site. Also at the OPS, we do a circle there. Yeah. One of the very few circles that are led by the Indigenous community that allow people under the influence to be into. And so I think that's something that is great. I'm also probably the only verbal, visual Indigenous person working at safe consumption sites and OPSs in Toronto. And then so there's something wrong right there in itself, that we need more Indigenous people working in the field, and we need to find a way to create that space for that and take away those barriers and those walls that we have. And that's not right. That I'm, one of are the only one working in these consumption sites right now, and that's not right. We need that. So. And the amount of people that use these services, one day that the OPS did a survey of how many people, of how they identified themselves, and it was over 50% of people that used that site identified as Indigenous that were using that site. And that right there itself shows how much it is needed, and we need to create that, not in the near future, but right now it is needed, because Indigenous people are using at such a high rate in these communities, and there are people that are great people and deserve the respect and love that everybody else gets in throughout Toronto.
All right, thank you, Les. Miigwech. We have two more speakers who've been added to the deputants who've been added on here. I have Gary Thompson next. Gary. Gary, you'll have the clock on your side. You know how this works.
Much. It's Joe Mahevick's birthday yesterday. I sent him a little birthday words of wisdom. 2 needless suicides. Oh, my love, my wife, death has sucked the honey of thy breath. William Shakespeare, Romeo and Juliet. Juliet took a sleeping potion, rescue breaths would have brought her out of a coma. Think next time, Romeo. Now to this issue. Great Spirit, the giver of the breath of life, animals have been observed giving respiratory assist to their friends in respiratory distress. I suggest stop harming ourselves and Mother Earth. Also, stop sending needlessly cousins to their ancestors, that we begin anew and start remembering the magic. Stop playing Russian roulette with our lives and everyone else's. Indigenous cultures do not implement anything that will negatively affect 7 generations into the future. The overdose protocols being taught are negatively affecting everyone now and how far into the future. Empower millions of laypersons what they think is a life-saving technique. They are eagerly following clinicians' instructions in the belief they are saving lives. Signs of overdose proves the heart is beating and could be any of the hundreds of causes of breathing emergency. Protocol increases mental and physical illness, drug use and abuse, loss of trust in the medical profession, addiction and harm reduction workers, dysfunctional society. Protocol, you deny grade school science, how the heart and lungs work. Page 4 of my handout, an email from the Executive Director at Health Canada, October 1st, 2018, to quote, some provinces recommend rescue breathing only, others chest compressions only, other jurisdictions advise both. Then turn to page 5. This is a new protocol being given out to Canadian citizens. All the signs of respiratory emergency and no mention of respiratory assist. August 2017, Moss Park overdose prevention sites. 6-month case reports, 168 overdose reversals, 67% with oxygen and stimulation, 33% with oxygen and naloxone, half the 33% EMS was called, complications, all survived. Moss Park teaching rescue breathing, thus saving the lives of non-drug overdoses. December 2018, Brad Chapman's coroner's inquest. Medical officer of health on the stand. City lawyer. Dr. Aaron's Orkin's testimony last week, quote, first aid, rescue breathing saves lives. Dr. Davila's response, I am not a resuscitation specialist. I hear first aid saves lives. Public health staff is trained to recognize and respond to an overdose. In the last year, we have had 25,000 clients and reversed 400 ODs, all survived.
Gary, I'm just going to ask you to wrap up as we're after 5 minutes.
Anyway, I'm suggesting that the city go after these people that are teaching this contraindicated protocol. You're making yourself sick and everyone else, and it's costing you a fortune.
Thank you, Gary.
Thank you very much.
Any questions for Gary? All right, seeing none, thank you, Gary.
Yeah,
We have one final deputant, Walking Wolf, who spoke, read Bradley Nolan's letter as asked to depute, as well in his personal capacity. The clock is on my right side here.
Ali, Mike Mosa just cuts my kin totem. Newfoundland, Labrador, and Nujunjubai. You heard my brother speak. My family's Anishinaabe. My ancestry is Innu and mixed settler. And my community and kinship ties are to the Anishinaabe, Oklahoma, and Lakota peoples. I just want to acknowledge Steve Teakins and the work that Namirez and Sagate Transitional Housing do. They're already doing harm reduction by providing housing and culture, language teachings, sweat lodge ceremonies. Those ceremonies are harm reduction. Ceremonies are treatment, prevention, and harm reduction. The fact that these ceremonies are available in transitional housing absolutely saves lives. I have no doubt about that. I want to speak about like the impact of what's really going on. Like people like Sigrid Neve, Oklahoma, myself, many other people, First Nations, Métis, Inuit, urban people, have been doing street work for a really long time, before even the overdose prevention centers were open. People like Zoe who were doing things on the street as well, and many other people. Just imagine for a second, when you lose people in your life, maybe people here, you go through like losing someone, death and grief, maybe a couple of times in your life. For many Indigenous people, we're in a constant state of grieving. Imagine losing dozens of people, or even more than that, every single year. When I lived in Namirez Sagate shelter, I myself lived in Sagate shelter housing when I was homeless. A friend of mine's name was Rains and Thundercloud. He completed his law degree while staying at Sagate. And he's one of the people that's been lost to this so-called opioid overdose crisis. I found out that he passed away. I lived with him. I found out on a streetcar that he passed away, and the streetcar actually had to stop, and I had to be brought out of the streetcar. I was so distraught when I found this out. Since then, I found out dozens and dozens of friends, loved ones, and community members. And, this disproportionately hits First Nations communities. The overdoses are hitting our communities hardest, and we need to have more services that are led by our people. In the harm reduction communities, we need agencies to support our call for funding, but also just to step out of the way and let us do the work. We don't need outside voices narrating solutions for us. We're capable of understanding those things ourselves within our communities. We just need the support. We definitely need that Indigenous overdose prevention sites. I created a pitch called the Elder in Residence pitch for Moss Park Overdose Prevention Site. It won the George Brown Social Innovation Award this year. And the idea is to bring a permanent elder that is available at Moss Park Overdose Prevention Site 2 to 3 days a week for one-on-one with Indigenous clients. I conduct a talking circle. I'm a shkabe, I mean ceremonial helper. And we conduct a weekly talking circle at the Moss Park Overdose Prevention Site. That's an example of ceremony that's low barrier, readily available, and bringing ceremony to the people. We want to do that in a more permanent sense with the elder. Have an elder there that can easily refer Indigenous clients, broad range of harm reduction options and or treatment, can quickly refer them to lodges, to medicine people. Moss Park's doing a really good job at developing referral relationships with agencies like Anishinaabe Health, and we need more funding to continue to do that work.
Just going to ask you to wrap up as we're over 5.
Yeah, no problem. So anyway, I just wanted to speak about that. I hope that brings like a lived experience to this room. We're doing the work. We have the solutions within our own communities. We just need primarily the support in terms of funding for these ideas.
Thank you. Just before you leave, are there any questions from the committee? All right. Seeing none, thank you very much. We're now going to bring this inside committee. So for new members of the board, this is the opportunity where we now have to ask members of staff questions on the report in front of us. So I'm going to open it up to the floor to see if there are any questions. Councillor Wong-Tam.
Thank you very much, Mr. Chair. I just wanted to ask of staff, some of the deputants, well, I think one of the deputants specifically talked about the process of consultation and what that feedback loop consisted of. And some of it, of course, was staff asking or the consultants asking questions by email and asking for answers by email. Were there other ways of soliciting feedback beyond that and beyond the circles?
So just to clarify, Councillor, the facilitator, Michelle Sue from Minnecaw Consulting, developed the consultation plan and led it and executed it. So I don't want to speak on her behalf, but to answer your question to the best of my knowledge, there was an advisory committee that provided some input along the way that got broadened as the project went along. The input points were advice circles with people with lived experience, and also a session with service providers. And she did a follow-up survey with service providers and got a number of responses that way. The feedback loop that she used was building on that input and aware of the need to try to get a strategy developed in as quickly as possible, I think. She then pulled the information together and circulated those recommendations and what she heard from the community back out to this advisory committee via email. So that was the email loop to that broader advisory committee on the recommendations and the report itself. Although she was very clear in my communication with her that, in her words, the people have spoken and this is what they want. So she was pretty strong that the recommendations that are in there, that continue to be in there, are what she heard from the people during the consultation phase.
Thank you very much. And with respect to, and only because there's not a lot of time, with respect to the suggestion that the recommendations in the report ask many things of the other orders of government, there's a number of headers that every recommendation almost starts off with, the Board of Health urges the federal and provincial governments to do ... I'm curious to know, is there anything else that the City of Toronto can do that can more directly, more urgently, and immediately support the Indigenous community through this strategy?
Right. So just to clarify, there may be a bit of confusion. So there's the recommendation in the standalone strategy itself, and then there's the recommendations in the staff report that covers it. And the recommendations in the staff report are the ones that fall within the purview of us as Toronto Public Health as a mandate. So we're receiving this report and responding to the ones in our purview, including advocacy to other orders of government. But we're also referring the strategy to shelter support and housing and other parties, I don't have them all in front of me, for them to respond to the recommendations directed to them. So if you look in the main report, you will see that there are recommendations directed to the city, and including public health, shelter support and housing, Toronto Urban Health Fund, those sorts of things.
I see that particular recommendation of forwarding the reports to those divisions, but there isn't a more public process for that. So those reports will be received by the directors of the GMs or the executive directors of those divisions, and they are to report through their committees, is that correct, on what they can do? Because it's not clear. The recommendation will be, the report will be forwarded, but it could end up sitting on a shelf unless somebody is able to extract it and put it through the standing committee. So there's another public process.
I mean, I guess, suppose you could ask for a report back. I will say that the divisions that are named in here have been consulted and spoken with during this process, so they're very well aware of what's in the report.
Yes, and through the chair, if I can speak to that, we're certainly going to make sure that we connect with our partners throughout city divisions and ensure that action is appropriately considered and taken.
Okay, and thank you. And my final question is with respect to the notion that a number of the existing service providers that are already out and up and operating, they're already being funded, but that they may not be meeting the specific needs of this particular population, especially with a harm reduction lens to their service. How do we respond to that?
So in part, I think that's the role of this Indigenous coordinator that we're looking to hire to help work with Indigenous service providers on those very things. So it's not up to us to tell Indigenous service providers how to deliver their services, but we've received some important feedback that we need to be sure that they hear and take on board, and if there's some way we can support them, as you heard from the deputants, to deliver more harm reduction-based services, then that would be our role in supporting that, not in doing it.
Okay. Thank you very much.
So, and if I can add through the chair just one final point in respect of one of your earlier questions, Councillor. I think that it is unfortunate that Michelle Sue, our facilitator, was unable to be here today. I would like to put forward for consideration, or at least mention the possibility of having Michelle Sue come back to this table perhaps when the weather is a little bit better, and so that you'll have the opportunity to hear directly from her. I think that would be quite useful for the board to consider.
Kate, yes.
I have a question with respect to recommendation number 6, which is 4.1 in the full report, around Indigenous-led consumption and treatment services as part of the new CTS program. And my question is around any evaluation of this work going forward. Are there particular indicators or metrics that are critical or important for an Indigenous-led CTS that might differ from a more mainstream approach to the long-term sustainability of that kind of program?
So through the chair, the recommendation calls specifically for an Indigenous-led consumption and treatment services. So I would imagine that along with the service provision, evaluation considerations would be the responsibility of that Indigenous service provider. We can certainly raise the notion of evaluation as forming an important component, but we would leave that to the service provider to make the best determination as to what indicators and what evaluative processes would make the best sense.
Just to clarify, I think my question was more around provincial decision-making with respect to the long-term sustainability of these programs.
So through the chair, I have no line of sight directly with respect to the provincial decision-making processes. I'm sure that they would have some degree of evaluation component as part of it. What the specifics would be in respect of an Indigenous-led consumption and treatment service, I think have yet to be understood and seen.
Any other questions? Councillor Lade.
Just very quickly, and I know this, it's not to the subject matter, but how exactly will we be communicating this to the various ministries and other levels of government?
So if I can, through the chair, traditionally what happens when it comes to communicating with other levels of government is that a letter goes from the chair of the Board of Health on behalf of the entire board in respect of the report that was received here today and the recommendations that you're making that you will either adopt or not adopt as part of this deliberation.
I'm going to make a suggestion when I speak.
Okay. Any other questions? Okay, we'll take this in now then to speakers. Speakers on the item. Councillor Lade.
Just 2 quick items. And one, my apologies for being late. I had an appointment run long that was scheduled when we met in the afternoon. We don't anymore. So my 2 suggestions. One is thanking staff for doing this work. I think it's incredibly important that we address our commitments under our statement of commitments to Indigenous people living in Toronto, as well as the calls to action from the TRC in addressing Indigenous-specific programming and funding so that we can better address the needs of Indigenous people living in Toronto. My 2 suggestions would be, one, when communicating it to the levels of government, and I won't do this by way of motion because I know the chair will follow up if he thinks it's appropriate, would be communicate this to other Toronto MPs and MPPs directly, including opposition members, just so that we flag this across the board on what has the Indigenous community in Toronto told Toronto public health staff needs to be done to address the opioid crisis in the city of Toronto. And I do this because far too often, I think we just submit these reports and requests to ministries, and it ends up in a stack of communication. And the ministers don't see it, and neither do any of the other caucus members who might want to take on and champion a file like this, including the opposition members that I think, and rightly so, have a duty to respond to the request made by the City of Toronto and Board of Health in this matter. So I would leave that to the chair to take whatever action he sees fit. The other is in the hiring of the Indigenous consultant or the permanent position. If I could just offer a little bit of advice, that we have two great resources here at the City of Toronto, one with our new Indigenous Affairs Office to give any thoughts about the hiring process, but we also, there's expertise within our HR department at the city around our Aboriginal employment strategy. And very specifically, they've got relationships with some employment agencies, as well as the recognition of some of the expertise that comes out of the Indigenous community that can sometimes get lost in our traditional HR practices. So again, you don't need a motion. It's just my advice. Thank you.
Thank you, Councillor Layton. Other speakers? Councillor Wong-Tam.
Yes, thank you very much, Mr. Chair. I echo the support for Councillor Layton's suggestion. I think that we're in some pretty dangerous times with the other orders of government, especially at the provincial level, perhaps not being interested or caring about funding certain programs that we know are life-saving and especially important for the communities that we serve. And I recognize that this report is largely speaking to obviously some work that the City of Toronto has to do, but we don't and cannot deliver health programs without the support of the provincial and federal partners. And as I read the political tea leaves, and we're all aware of the headlines of what's happening, I have some grave concerns that vulnerable populations that are already subject to harm, that are already feeling left behind, are going to continue to fall through the cracks. And so therefore, as well as this this report is out there laid out, and it has some key recommendations, I am very, very concerned that we will not get the support that we need from the provincial government in particular, which means that we're going to have to do a pivot in the 2020 budget if that continues to be the case. And that pivot will be, what do we do as a city, as a local government, to support the communities that live in Toronto? And we know that these are not necessarily services under our purview, but I cannot imagine an agreeable solution would be to say that's not our responsibility. And I think that having sat and listened to a number of deputations, these ones today, which were so eloquent, but also in other committees that we all sit on, and especially for the councillors who are here, we cannot be in a position where our response to the communities that are coming forward asking for support, especially around life-threatening emergencies, is that it's not our responsibility. I'm just putting that out there. I know that we can't do too much right now in the 2019 budget because there's already so much in there that's a fight, but in 2020, this path, as we get to drafting that 2020 draft budget, which will be drafted by staff very shortly, we're going to need to make some big adjustments, and I think that pivot will require us taking on more temporarily until we actually get another order of government another government in Ontario that is actually going to care about these issues. Thank you.
Thank you, Councillor. Additional speakers? Okay, I have a few comments, and I can begin by placing a motion that the board request Michelle Sue, who was the principal who led and facilitated the consultation process, to participate at a future meeting of the board on account of the weather. Unfortunately, at the last moment, she was not able to be here today. Just a couple comments in light of the report in front of us and what we've heard today. I would start with the principle that I think is critical in thinking about the Indigenous strategy, which is nothing about us without us. And I think we've heard that not just throughout the consultation leading to this strategy, but from our deputants today. And to that end, I want to thank members of the Indigenous community who were part of developing the strategy and spoke to it today. And I'd also like to thank and recognize the Medical Officer of Health and Susan Shepherd from the Toronto Drug Secretariat for their work on this. When it comes to overdose, we know far too well that overdose deaths are preventable deaths. And in recent years, as we have talked again and again and again about this escalating crisis, we know that there is a disproportionate impact on Indigenous Torontonians and Canadians, and that is unacceptable. It is wrong. And so when we developed as a city 2 years ago the Overdose Action Plan, we heard from the community at the time that that disproportionate impact needed to be addressed yesterday. And so the strategy in front of us today is the outcome of that. And it is a model, I think, quite importantly, that speaks to Indigenous services, that should be delivered by Indigenous service organizations and conducted by Indigenous peers, because that's the model that works. That's what we've heard from the community. And so whether it's harm reduction services like an Indigenous specific overdose consumption site, or treatment services that utilize and build on traditional approaches of care, including healing circles, or prevention work that actually have Indigenous peers who are doing the frontline work. All of this is long overdue and necessary. I will acknowledge a concern I often have when we bring forward what I think are thoughtful and important proposals and strategies like this, that we are dependent, as always in healthcare, on other levels of government. And I'm often worried that we are too reliant. And so as we look to continue to implement not just the Overdose Action Plan, but this strategy, this will be coming back, a full report on the outcome of this strategy and its implementation next year. We'll have an opportunity as part of that to hear from a new Indigenous staff person lead at the city on it. But to Councillor Layton's feedback, I will take on, certainly in my capacity as the chair, not just to ensure that I reach out to the ministries, but also the members of Parliament and provincial Parliament. And I'll just conclude by saying that, 10 years from now, I think we'll look back at this point in time at the lives that have been lost, the families that have been impacted, the devastation that the drug war has wreaked havoc on our city, and we'll all collectively wonder why we didn't act sooner. All levels of government. That why we allowed people to die needlessly. And I think this term, especially for new members of the board who are here today, perhaps there is no more important task than continuing to confront the overdose crisis. And I think you will see at meeting after meeting that we will hold ourselves to account just as we will hold other levels of government. And so with that, I'll conclude my remarks. And I don't believe we have any other speakers. So I have a motion on there. Can we take the motion as a package with the staff recommendations, or do we want to vote on it separately? Together, okay. So the motion as the staff recommendations as amended with my motion. All those in favor? Opposed, if any? That carries. Thank you. We'll now move on to our next item, which is item 3.2, expanding opioid substitution treatment with managed opioid programs. We have a speaker registered. I'd ask if Reid Siemianuk, I apologize if I mispronounce your last name, from the Department of Health Research Methods, Evidence and Impact at McMaster University, to come forward. Reid, you'll have 5 minutes. The clock is there on your right. And so when you're ready, I'll get that started.
Is the microphone working? Yeah. So I'm a specialist in internal medicine. I live in Parkdale, and I work mostly at Etobicoke General Hospital. Internists I'm the person that sees the people who have a lot of these acute complications that need to come into hospital and are at risk of dying or are dying. And I'm here to speak to this motion full in support because frankly, I'm sick of having to bear the responsibility of telling families and patients that they are dying or they have died or they're going to be left with lifelong complications that are entirely preventable. And the injection opioid programs are one critical piece that we need as healthcare providers that we do not have right now. I only have 5 minutes. I wanted to tell you a couple of stories about people that have changed the names that I think are important. There was a gentleman, Michael, who was involved in a motor vehicle accident. He was prescribed opioids and unfortunately became dependent on them. Like we see all too many times, eventually went to illicit sources on the street, started using injection drugs, tried methadone, didn't work with the methadone in the oral programs, went back to using injection drugs, and one day he overdosed, came in, and he didn't die, but now has irreversible brain damage and is living in assisted living forever. He's a shell of his former self. His 2 children who are in their early teens will never be able to be raised the same way that they would have, and his family is left now living, frankly, in poverty because his wife is trying to raise 2 kids that she couldn't before. And this isn't something that I see all the time. So the deaths do not represent fully the picture. There are people who are suffering from major complications of opioids that are preventable. Another one is infective endocarditis. Endocarditis is a infection of the heart. People who use injection drugs, especially people who use injection drugs from sources on the street or from crushed pills, which is a common way to inject, are at higher risk of infective endocarditis. Endocarditis kills people. It results in a lot of complications. It can result in stroke, it can result in death. And we're seeing in Toronto and in Ontario that the number of injection drug users who have had endocarditis has gone up by 150% over the past 10 years, despite the fact that actually we haven't seen a big difference in the number of people who are being admitted to hospital because of complications of injection drug use. Opioid injection, safe supply of injection opioids would solve a lot of these problems. We have actually pretty good evidence from high-quality randomized trials that prescription injected opioids like heroin, like hydromorphone, lead to much better outcomes. We know that the retention in opioid agonist treatment programs from the trials that have been done at 1 year is less than 50% with the oral options such as methadone, Suboxone alone. It's over 90% when you have availability of the safe supply of injection opioids. In those studies, there is a 20% absolute reduction in the number of people who are using illicit sources of drugs. At the end of the year, there was a reduction in hepatitis B, hepatitis C. Hepatitis B is not curable, by the way, and leads to complications many years down the line. There is an increase in the number of people who were on oral substitution programs, such as methadone, after 2 years. There was a reduction in illegal activity. So there was a reduction in the number of crimes, petty crimes, and other criminal activity. And anecdotally, there's also a reduction in, especially for women, but also men, in people being vulnerable and moving to the sex trade to pay for their opioids. So at least in Netherlands, where they did one of these studies, and also in BC, the costs were easily paid for by the reduction in health spending, as well as the reduction in social justice costs through police and jails. The last thing I'll say is that hydromorphone right now as injection drugs is way too expensive. It's not covered on the Ontario Drug Benefit Program except for palliative care. BC has negotiated a price specifically with the manufacturer of injection hydromorphone.
And I'm just going to ask you to wrap up as
Okay, and so it is available there. This is being used in Canada already. This isn't something that is particularly progressive or groundbreaking. It's something that we need urgently, though. Thank you.
Thank you. Questions? Seeing none? All right. Are there any other deputants on this item? We have no question.
Thank you.
You're good. Thank you very much, Reid. Do we have any other deputants? Seeing none, we're going to take this into committee. Are there any questions of staff? Councillor Wong-Tam.
Yes, thank you very much. The speaker was talking about, mentioned that BC has a program that now funds and supplies hydromorphine. Is that hydromorph? Morphone. Thank you. What are the chances of this happening in Ontario?
So through the chair, this is exactly what we're aiming for, to provide a broader range of options. I think you've heard through a number of deputations, or the deputation for this particular report, but as well through deputations from the preceding report, that in fact there are existing opioid substitution treatments that have been longer standing. They don't always work for the various people who do try them, and I think that we have seen in other jurisdictions, British Columbia, Alberta, Ottawa now, and certainly jurisdictions elsewhere. We heard about the Netherlands, Switzerland. There are many jurisdictions that are doing this. I think we have strong opportunities. We're actually in the process of working through a potential pilot. There's some funding. One of our partners here in the city looks like they're going to be able to proceed with. We're just in conversations with them now, and we hope that's just the first of many.
Is there any way for us to proceed with a pilot without Ontario's permission and funding?
You know, through the chair, I think that would be extremely challenging, if not impossible.
And it would be impossible for what reason?
Through the chair, for a variety of reasons, not the least of which these involve funding to healthcare providers who are generally funded through the provincial government. So as well, depending on the substance that we're looking at here, when we're talking about products like, for example, diacetylmorphine, we actually need the help of our federal partners, as there need to be special permissions in order to actually get access to product. So for a variety of reasons, we need both our provincial partners in some cases, and in other cases, provincial and federal partners.
So from the province, we require funding, and from the federal government, we would require permissions to use certain types of legally sanctioned medication.
That's correct. We would need special permission for those things, although we certainly wouldn't scoff at funding from the federal government if they were to provide that.
Right. Okay, thank you very much.
Thank you, Councillor. Any other questions on this? So I just have a couple, just building on Councillor Wong-Tam's question. So my understanding, there was a recent announcement of a little more than $100 million in both federal and provincial funding for treatment. Is that correct?
Yes, that's correct.
And so traditionally, it is the LHIN that provides the funds, and Toronto Public Health and other service agencies administer those funds on substitution treatment models?
So whether we actually administer those funds, oftentimes it's really the provincial government that tends to fund health care, and this would certainly be seen as a health care program.
Okay, thank you. We'll take this in. We'll now move to speakers. Speakers on this item? I'll only just say a few words, which is to say the Toronto Drug Strategy has pillars: treatment, prevention, harm reduction, and enforcement. And so just as we had a specific conversation on an Indigenous strategy to look at a tailored approach to look at all of those pillars, here we're speaking concretely to one component of the Toronto Drug Strategy in our work, and that being treatment. And just as we heard just the other day about heroin clinics that have opened and are opening in British Columbia, that as we talk about how do we prevent the unnecessary loss of lives, when in many ways we have an issue of drug poisoning, which is taking place. As we think about opioid substitution treatment and the role of public health, there certainly is a role for us to make recommendations to the province But I would echo Councillor Wong-Tam's comments, which is the province may fund the healthcare and healthcare delivery, but if we do not have an ally in the province in the delivery of some of these resources, we may need to think about more direct municipal federal partnerships in the delivery of substitution treatment as we seek to combat the overdose crisis. And those are the only comments I would make. And I'm happy to move the Medical Officer of Health recommendations on this report. With that, all those in favor of the recs? Opposed, if any? Carried. We'll now move to the third item on our agenda. Nobody's really talked about this, edibles and cannabis. Anytime you put lollipops, edibles, and gummy bears and cannabis in the same sentence, everybody seems to have an opinion. Very colorful. I don't have any pre-registered deputants on this. Is there anybody here who would like to speak to this item? All right, seeing none, we're going to move straight into committee then for questions. Questions of staff. Trustee Donaldson, questions?
Thanks, through you, Chair. In item F, it says require edible cannabis products in a single package container to reflect traditional consumption portions of similar products without cannabis. What is a traditional consumption portion?
Through the chair, that's an interesting question, and it will vary from product to product. So the notion is to try to reduce the likelihood of over-ingestion because you've got a certain, cannabis contained in a smaller sort of package. So for example, if the traditional amount consumed is one package or one portion, then a singular regular dose, if you will, of cannabis should be contained in that, rather than say a tenth of it or a fraction of it. Because then if you eat an entire package, you're getting whatever, 5 times, depending on how it's packaged up. So that's the rationale behind that. Thank you. You're welcome.
Yes, thank you very much. This report is largely asking the federal government to limit the access and to prohibit the access of edibles for younger people, for youth. Are those conversations have those conversations not already initiated, especially by way of through the early round of consultation around legalization of marijuana?
So through the chair, there were many conversations, certainly, and yes, there were conversations around limiting youth access with the first round, if you will, through the legalization process. However, as the report indicates, the federal government has committed to expanding access to cannabis edibles and cannabis topicals and cannabis extracts. These were not included most recently in the last 6 months when cannabis was legalized in this country. The federal government undertook to actually expand to these products. They are undertaking, or they have recently undertaken, consultations. These are a reflection of some of the recommendations that we made in response to that consultation process. The plan for the federal government is to expand legalization of cannabis to include edibles, extracts, and topicals no later than October of this year.
And in those early conversations and then the second round of consultation that's now beginning, the position that Board of Health and yourself as the medical officer has taken is that we need to limit access, especially for young folks as their brains are still developing. What has been the early response from the federal government on that?
So through the chair, my understanding is that our federal counterparts have indicated that their primary objectives through legalization are public safety and public health, and particularly limiting access to youth. We looked at the proposed regulations such as they've been put forward by our federal counterparts. We've put forward these further regulations, I think, that get at that goal of limiting access to youth exposure for precisely that reason you were describing. We know that young people's brains are still developing until about 25 years of age. They're therefore more sensitive, more likely to experience harm associated with early exposure. That's why we've actually put forth these more stringent, if you will, recommendations around how to limit youth access and youth exposure.
And is there anything more that the City of Toronto can do today? Because I know I can walk into a number of businesses and purchase edibles. They may not be, and some of them are prominently displayed, some of them are not. I can purchase them online. It is already accessible. We can make the purchase. We don't have to wait to October, and yet we have no guidelines to protect young individuals. Is there more that the City of Toronto can do to protect those individuals now?
Well, I think through the chair, some of the things that we are doing is engaging in education campaigns, trying to make sure that parents and caregivers of young people and young people themselves are aware of the risks associated with early exposure and frequent early exposure to cannabis. So I think that we're over and above the guidelines or recommendations that we've put forth in this report. We are actively trying to make sure that people are aware of the risks and are best equipped to make decisions for themselves.
And how involved has the school boards been in the development of this report? Or are they doing their own work and they're submitting their own set of remarks to the federal government?
So through the chair, the recommendations here are our recommendations as Toronto Public Health. Our school boards are important partners in respect of ensuring that our youth get appropriate access to, important messaging on how best to protect their health. I'm not certain, I don't know whether our staff know whether in fact the school boards participated in the consultation process that was open to all Canadians to participate in, but certainly we are actively in conversation with our school board partners on this and many other issues relevant to youth health.
Yeah, we're not aware of what submissions the school boards have made. Yeah, we haven't consulted with them on this report either.
Thank you.
Do you support the legalization of edibles?
So through you, Mr. Chair, yes, we do support the legalization of all drugs for personal use. That's been a stance we've made very clear and in fact was supported by this board.
Are edibles a benign substance? Are there potential negative health impacts associated with the consumption of edibles?
So to be clear, Mr. Chair, there are negative impacts and potentials for harm associated with all drugs, whether they're legal or illegal currently.
And so edibles specifically, edibles are different than the inhalation of cannabis. And so are we aware of the difference in which the potential harm associated with edibles compared to inhalation? Is there a difference in how that harm can be experienced?
So yes, in respect of cannabis particularly, we know that smoking cannabis poses certain risks. There's risks with respect to brain health, as we've discussed, particularly amongst young people. But when it comes to smoking, there's also lung impacts as well that one has to be mindful of. Those kinds of impacts are not seen when it comes to consuming cannabis, by mouth.
Okay. Now, following the legalization of edibles in some states in the U.S., in Colorado, what was the experience, the early experience, following the legalization of edibles in those states?
So as I understand it, what happened in Colorado and Washington were that they noted that there was an increase post-legalization because they included edibles right off the bat. There was an increase noted in accidental ingestion of cannabis products by children, particularly those under the age of 9. And I think what was very troubling from the perspective of public health authorities within those jurisdictions was that a significant proportion, it was almost 35% of those incidents actually led to hospitalizations. So preventable hospitalizations, and I think, so we see issues at the individual level, but also at the societal level.
Now, some of your recommendations speak specifically to the form in which edibles can be produced and sold, such as in forms like gummy bears and lollipops that may be appealing to young people. Your recommendation here, a clear one, is that that should not be produced in that manner. Why is that?
So as I just mentioned earlier, this was the experience within the context of other jurisdictions that legalized ahead of us. They noted that accidental ingestion of cannabis products increased post-legalization, and that a significant proportion of those cases were in fact due to products that were appealing to youth and young children, mistaken as just regular candies, and in fact were cannabis-containing candies. I think the other important element here is that there is a unique appeal, a particular appeal to youth of these formats, and that concerns us in the sense that, again, we're trying to limit access to youth because we know that the brain is still developing until about 25 years of age. So we're trying to ensure that young people are less likely to start using cannabis products before that time when their brain is fully developed, so as not to experience the harms associated with cannabis.
Okay. Those are all my questions. Any other questions? Seeing none, we're going to move into speakers. Sue Wong. Sue.
The federal government, more specifically the local MPs, aware of these recommendations. Because I remember when I was at Queen's Park, you guys do wonderful things. I never heard of them, you guys. I heard it from the media, okay? And it is so critical. It's now 10:30. It's question period, my friends. An opposition can ask a question, or maybe the government side can ask a friendly question. It won't be very friendly, right? Let's put it this way. But I think the bigger issue here is, with regard to cannabis, it's here to stay. There got to be measures from this board to track, to evaluate, but also work in partnership with different organizations to ensure this product, because it's here. This is the new tobacco. We've been fighting tobacco for 30 years, right, Mr. Chair? And I was the forefront of tobacco back in the 80s when Counsel Layton's father and I was batting this issue up, getting rid of tobacco in restaurants. But I think a bigger issue here is how do we ensure young people, because when I was meeting with my counterpart in Washington and Colorado, the #1 issues after the edibles was introduced in those states was the poison control hotline. It went off the roof. So we need to make sure future report coming from staff to this board have those information so we could be advocating. And I was very pleased to see the 2 school board trustees are here on this table, because the good old days when I was here before, there was alternate. So it's very, very important that how do we ensure these recommendations is shared with local MPs, but more importantly, the school board trustees as well. Because when we advocate positions on this magnitude, we need to work with partners. Partners included the 2 school boards, because for years, the Catholic school board was not on board. I was here long enough to know about that, okay? So we need to make sure that public education doesn't stop here. We need language, informations that are simple and understandable in a diverse community. And more importantly, how do we work with student trustees? Because they're more smart than us. They can create those apps and what have you. How do we work with them and create that opportunity for them to create that stuff? So, Mr. Chair, I really want to say thank you to staff for this report, but we got lots of work to do years ahead and months ahead.
I just wanted to add to Ms. Wong's comment about we need to actually educate the public on this as well. It's very important that we don't just run with the report, but how we disseminate them through different channels. The media is very important, like social media, whatever, apps, or for younger people that they can relate to. I think it's very important that we, there's a role for us to actually educate some of these risks especially for the youth as well. Thanks.
I just wanted to thank Sue for her comments, and I don't want to speak for Trustee LaPrete, but we'll be talking and bringing this back to our boards. And also, I note the timing on it too, because the legislation might be amended, and October of this year, and then the timing for regulations. So it's also one of those things that can't wait, and we can work on now within our own communities and our own school boards. Thanks.
Thank you very much. There is a motion I'd like to move, and Julie just received it, so I apologize that it's happening so quickly. But I can pretty much say that the motion is to request that this report be forwarded to all the school boards, all the Toronto-based MPs and MPPs, and thank staff for the report. And thank you, former MPP Sue Wong, for highlighting for us that the work that we do at the City of Toronto is not always picked up at Queen's Park, and clearly we need to do a better job of communicating, especially as it relates to important reports and documents that we want a set of eyes on in another order of government. So that's strictly my recommendation, not much more than that. And I know that our good chair would have done it anyways, but now it's out in the public.
I haven't been here, but
Okay. So.
All right, any other? Sorry, any other speakers? Okay, I'll speak. First of all, legalization is long overdue. I mean, for the notion of just say no, trying to arrest your way to a solution, it didn't work. It didn't work. And so it's a good thing that we're finally at the point of legalization and that edibles will be coming forward in a legal framework. But we endorsed and supported legalization to remove the harms associated with criminalization. There were many. We had people getting criminal records that had a lifelong impact on them needlessly. We had a disproportionate number of people, frankly, people of color, who were getting those criminal records. We had a black market that was uncontrolled taking place. And so we wanted to remove the harms associated with criminalization, but we also want to mitigate the harms associated with consumption. Cannabis isn't a benign substance, and so we have to get this right. I mean, Canada's only the second country in the world to legalize cannabis. Uruguay is the only other country that's done this, and so we've seen experiences by some states in the US, we've seen other approaches, such as in Portugal around decriminalization, but we are now the second country in the world to legalize cannabis, the first in the Western industrialized world, and we need to ensure that there's a public health approach overseeing this. And we need to think about this as Sue Wong said, just like tobacco, it might be legal, but we don't want people to consume tobacco. So you need restrictions on advertising. You need quality control and regulations for edibles on the quantity of THC that is used, because edibles are different than inhalation in terms of how it's metabolized in the body. We need advertising restrictions, public education on labeling. And so just as legalization may be overdue, we don't want to end up with a framework whereby everybody's excited to consume edibles, is looking forward to it, is walking down the street with lollipops. In fact, we need to lead the discourse around legalization from a public health approach, and I think for this Board of Health to step into the front on it and to ensure that our school boards are part of the discussion, that elected MPs and MPPs are aware of the conversation, we have a chance here to lead the discourse on a public health approach to drug policy, but we need to get it right. And so with that, I think we can move into voting. We have an amendment first from Councillor Wong Tam, if that can be put on the screen. So this is the amendment as Councillor Wong Tam spoke to around forwarding the report. All those in favor? Opposed, if any? Seeing none, that carries unanimously. On the item as a whole, now amended, all those in favor? Opposed, if any? Seeing none, that carries unanimously. Thank you very much. All right, we'll now move forward to item 3.4. This is the 2019 Board of Health Committees and Appointments. So we have a series of appointments to take place here. And I think what we'll do is move one by one through these. The first one is we need to appoint 3 to 4 members to the Performance Appraisal of the Medical Officer of Health Committee. And so can we place on the screen? Sure. So we need 3 to 4 members to be on the Medical Officer of Health Committee. I've heard from Peter Wong, who has indicated a desire to be on the committee. If this can be put on the screen. I've heard from Councillor Wong Tam, this is item B here, who's interested in being on the committee, as am I. Is there anybody else interested in sitting on this committee? It's 3 or 4. We have 3 currently, but is there anybody else interested in being on this? Okay. On the first one, the Board of Health Budget Committee. There's nothing more exciting than the Board of Health Budget Committee, I can promise you. We need 6 or 7. We need 6 or 7 members on this. I had heard in advance from 5 of us, from Ashna Bowery, who can be here today, myself, Trustee Donaldson, Angela Johnson, and Councillor Perks. We need at least 1 more, but there's space for 2. Sue Wong is interested. So we now have 6, so we have enough. Is there anybody else interested? Okay, so we have 6. We'll keep running down. We need 1 person a citizen member to serve on the board of the Association of Local Public Health Agencies, and there's 1 space there from the Board of Health at a citizen member to sit on it. I've heard from Kate Mulligan who's interested. Does anybody feel like having a battle royale against Kate Mulligan for this seat? Or not so royal. So Kate has expressed it. Is there anybody else who's interested in that? Kate, well done. Let's keep moving along. Item D, this is the Urban Health Fund Review Panel. We need 1 person to sit on this. I know Trustee Donaldson reluctantly expressed interest, very reluctantly, if there is somebody else who's interested. So if there is, it was a reluctant offer. So if there's somebody else who's interested, do you want to do it again? I'll do it again. Okay. So that's fine. Okay, so we can remove Stephanie. Kristen is offered. I know you've served your time. All right. Item 2, this is on the Drug Strategy Implementation Panel. Councillor Perks, a longtime former chair, has kindly indicated an interest to step back into the chair's position, and so I will be moving that. And is there, so that is all the positions. So I would just check, is there anybody in A through D? Is there anybody else who's interested in sitting on the Appraisal Committee, the Budget Committee? If there's anybody else? On the Appraisal, okay. So if we could add Cynthia Lai, that fills out the 4. Okay, so we have a roster here. So if I don't see anybody else, I am going to move item 1. First of all, so that's to appoint the members below to A, B, C, and D, to the Budget Committee, the Performance Appraisal Committee, Alpha, as well as the Urban Health Fund Review Panel. All those in favor of the names listed there? Opposed, if any? That carries. I'm now going to move item 2, that the Board of Health appoint Councillor Perks as chair of the Toronto Drug Strategy Implementation Panel for the term. All those in favor? Opposed, if any? Carried. Thank you, Councillor Perks. And can I check with the clerks? Is there another motion we need to move on this?
Adopt as amended for the balance.
All right. So to adopt as amended. All those in favor? Opposed, if any? That carries. Thank you. Our next and final item on our agenda here today is Health Relief Services Update. This is item 3.5. We have a visiting councillor. You can please join the table with us. Oh, you want to speak there? Councillor Matlow. Yeah, you can sit as a visiting council. Absolutely. Let me just start by seeing, are there any members of the public who wish to depute on this item? Okay, so we're going to move into committee, and we're going to start with questions of staff. I'm going to begin for new members of the board. When we have visiting councillors, those are councillors who are not a member of the board, we always start with visiting councillors before taking it into committee. Councillor Matlow, do you have questions on the item for staff? No? Okay. Questions of staff, Councillor Perks.
Okay, I have a couple of themes that I want to get to here. So we considered a report from the Board of Health on this topic at January's council meeting, and there were a number of motions council moved. One of them was that the Deputy City Manager for Corporate, it's a new title, Corporate Services, work in collaboration with Toronto Public Health to develop a bylaw requiring tenants to provide an up-to-date voluntary contact list. And I just wanted to see if if there's been any response to that internally in the public service yet.
So through the chair, I'm going to hand that over to my colleague Gail Bursey.
Oh, yes, that direction from January 30th is active. The slight amendment that we got at the council meeting was to look at, rather mandatory, but look at it voluntary because of issues related to privacy. We're investigating those issues with legal and with MLS. And there's
but the
also
work
an
is
example,
live.
Sorry?
The work is live.
Work's live, and there's this issue around privacy and voluntary. We did find a report that you had mentioned that was done in the Parkdale area in 2012 that we're using as a reference where they developed similar lists.
Okay, and on the issue of voluntary and mandatory, yes, there is an issue of privacy for someone who lives in a unit going on the list, and that needs to be voluntary. I just want to make sure we don't accidentally conflate that with it's mandatory for the landlord to provide us with what they have.
Understood.
So we're clear on those two pieces? Okay. The second piece that Council raised was requesting the Medical Officer of Health to include in the 2020 budget proposal measures for better promoting the cool centers and measures for enhancing the, I forget what we called it, neighbor checking program. I don't see these here as recommendations. Would it be a problem if we added those as recommendations? I'm not saying you have to put it in the budget. I'm just saying give us something costed when you present the 2020 budget so at least we know what it would cost if we're in a position to move things around. Is that fair?
Through the chair, I think that that's a reasonable thing. However, just so you know, Councillor Perks, the notion of the voluntary program that you just spoke of, it's actually already included for 2019.
I understand. I'm asking about further enhancements.
Further enhancements, okay.
Just to do some thinking, so that when you present the draft budget to the subcommittee and eventually the full Board of Health, we have something that's costed. My frustration in previous years has been not giving direction early enough. We're in the middle of the budget process. I ask, what would it take to do X, Y, or Z? And the answer I get back is, well, I can't tell you that in 2 weeks.
Right. So
would it be fair to ask you to do that?
I think that's perfectly reasonable.
Okay, thank you.
Thank you, Councillor Perks. Other questions of staff? Okay. We're going to move into speakers. We have visiting Councillor Matlow.
Thank you, Mr. Chair, and thank you to all the members of the board for your attention to this matter today. My involvement in specifically trying to address providing relief for tenants in buildings that are suffering from excessive heat began back in 2011 when I started hearing from residents during the shoulder seasons, and I brought forward various motions to ask City Hall in general, both staff and the board, to address it. And it's been incredibly difficult for, in fairness to staff, to really arrive at the best proposals to be able to move forward with. But that doesn't obviously address the reality that when we have units during the shoulder seasons that are often going to 80, 90 degrees. And I've had repeated visits with seniors and other vulnerable residents where not only is their apartment itself just it's boiling. It's they are subject to potential heat exhaustion, heat stroke, even potential death. And that's why we've been saying this really is a critical matter to address as soon as we can. And when there have been proposals such as the cooling centers, certain rooms allocated in each building, that's a contribution, but the resident who is 80 with a mobility challenge, for example, would say, well, not only do I might have trouble getting there, but for anybody else, why shouldn't I be able to sleep comfortably in my own home? I'm not going to be able to use this cooling center all night. So it doesn't really remedy the problem. And staff have continued to struggle with what is the remedy. What Chair Cressy did, I thought, was a very very good effort, which is that he and I have worked together on arriving at a motion today that will at least put in front of you a couple of next reasonable steps to be able to ensure that the community, both tenants and landlords, are aware of what the expectations are each year. The reality is that while we have these arbitrary dates, September 15th to June 1st, when we expect that the heat be at 21 degrees Celsius, 70 Fahrenheit, we all know that that isn't always the reality in the middle of May when it can get up to 80 or 30 degrees Celsius. So that needs to be addressed. Now, the reason that I suggested that maybe the medical officer of health, just like extreme heat days, go out, in front of the media, in front of the public and say, this, landlords, please be reasonable, is because there weren't enough landlords who were listening, who were being reasonable. My experience in the last few years, and including last year, was that some landlords were reasonable, but far too many would either not want to either turn the AC on or turn the heat off because they were frankly being selfish and they were worried about costs. Some had concerns around turning it on and then it would take a couple weeks and how difficult would it be to do that. Others, I think, legitimately were worried that because of our bylaw that they would be fined, and they didn't want to be in violation of the bylaw, even if they could have done something. And that's why it's not only important to take a second look at really what these dates mean. Should they be set in stone? Should there be more flexibility allowed within the bylaw? What can we do to support retrofitting within buildings to make sure that the buildings themselves can allow for cool air to circulate in the units? And ultimately, if we have bylaws that seem arbitrarily restrictive, but with good motivation, we want them to turn the heat on when it's too cold outside, obviously, and we don't want them to skirt on that. How do we make sure that there is a formal declaration by a person of authority, whether it be the medical officer of health, whether it be the mayor, whether it be a title that we create and we provide that authority to them, but some way be able to get out there to the ears of the landlords to say, be reasonable. Do not keep the heat on just because you're worried that it's going to get a little cool maybe 5 days later. The last thing I want to mention about that is that some will say, well, what if it gets cold in 5 days in May? Well, it is far easier, and I hear this from tenants all the time, to put a sweater on for a couple of days than to escape the extreme heat that they are boiling in their apartment. So with that, I'm coming to my time, but thank you for your attention to this.
Thank you, Councillor Matlow, and thank you for joining us here today on this. We're now going to move this into committee, and I have Councillor Perks up.
So every once in a while, there's some kind of a health emergency or disaster that a government has carriage of. And the question that's always asked is, why didn't you act sooner to prevent this problem? We have good, solid evidence that this disaster is going to happen in Toronto and happen over and over again. The climate modeling that we have seen and has been presented at this Board of Health going back almost a decade now makes it very plain that we've been lucky so far, that the amount of heat and the length of hot periods that you need in order to have an emergency has already happened in Central Europe. It has already happened to the south of the Great Lakes in Chicago, and it's entirely predictable that it's going to happen here soon. Beyond that, within a few decades, the kind of heat emergency that will kill people is going to become the normal summer in Toronto. In an exercise done jointly by our Office of Emergency Services and the Medical Officer of Health a couple of years ago, we identified that over 100,000 Torontonians are at risk of death in the event of a heat emergency. And the infrastructure in the apartment buildings and rooming houses and older houses in the City of Toronto that have been cut up into apartment units simply will not be adequate to deal with it. One of the outcomes in that sort of modeling exercise, gaming out how Toronto would fare in a heat emergency, was we would not have enough body bags. So we know this is coming. And we know that from what we've seen in Central Europe and what we saw in Chicago within the last decade, the number of people who died can run up into the thousands. And that we are not prepared in any way to prevent those deaths. So here we are in one of those moments where we can act with foresight so that next year or 10 years or whenever the first true heat emergency hits Toronto, we can say we acted and we saved lives. This is one of those moments. So I urge you all to support the recommendations Councillor Cressy is going to add, the good work that Councillor Matlow has undertaken, and the work from the Medical Officer of Health. Thank you.
Thank you, Councillor Perks. Other speakers? All right, I will speak. Oh.
Sorry.
No, don't apologize. We're still getting my motion ready, so this is great. Trustee LaPredi.
I just want to say thank you for this report. It's very important that not only are the seniors being affected by this, but so are the children in our schools. A lot of our schools do not have air conditioning, so we might not be getting, we might assume that they're getting the heat relief when they walk into our schools, but a lot of times there is no heat relief. We don't have filters in our schools, there's no ventilation, so it's stale air that at 9 o'clock in the morning we have students that are fainting, we have teachers that are fainting, and we can't expect our children to be sitting there. We are looking at ways to circumvent that within the school board, but I think that it's very important that we have this report. So thank you.
Thank you. Thank you, Trustee LaPredi. Sue Wong.
Thank you very much, Mr. Chair. So when I read the report, I notice on the bottom of page 3, it talks about the summer season. I think heat probably started in spring. Like we start seeing heat alert as early as probably April. I would say I wouldn't put the summer season. I think we're going to have to be mindful the fact that this climate change is real. Some people think it's fake news, but the fact that we are looking to work with partners, and I see that 180 locations being considered, I would push back the 2 trustees who are here today to identify which schools that are air conditioned should be part of these expanded 180 locations. Because at the end of the day, Mr. Chair, through you to the staff, I'm worried the folks that I used to serve in Scarborough don't know where these 180 locations are, okay? They don't have the capacity, press 311, say, press 3 for Chinese, press 4 for Tamil. Forget it, my friends. When you have an emergency, I need to know soon, now, I know it's middle of winter, because these 180 locations need to be communicated early, repeated, and repeated, and repeated. Because at the end of the day, we don't want an emergency because those heat-related deaths are preventable. Just like we just talked about the opioid crisis, those deaths are preventable. And how do we ensure the staff with the city communication plan, because this is not the Board of Health creating the communication plan, because the rural, the suburb folks don't have communications, they don't have the internet, they don't have printed media, they're the most vulnerable. I was at a TCHE building that we own, the city owned. It was like a furnace in the middle of June, okay? And I said, why don't you call the city council? Who's my city councilor? Okay, this is what I'm concerned about. We own these properties, and we're the landlord, and the tenant didn't even know who to call. Okay, so forget about this 180 location. That looks nice on this file in front of my computer. But my friends, we need to figure out how do we ensure city hall communication, better communicate about these locations, because the Scarborough folks, Councillor Lai would tell you that your constituents in Scarborough North would not have any means to Scarborough Civic Center for the cooling center, unless it's a neighboring high school that they could go to, okay? And the transportation, that TTC token is becoming inaccessible. So where's the water? Is there a stockpiling of water so that they can go to get water? Because hydration is so critical for little ones. So, Mr. Chair, I really support this. I think we need to do a very comprehensive communication strategy in light of these recommendations.
what is this when we talk about heat relief? Councillor Perks has spoken about climate change and inclement weather and how this is a pressing public health concern, not just today, but it will increasingly be one in the future. We've heard about how it's taking place in schools from trustees here. We also know that there are 3,400 buildings in the City of Toronto that don't have air conditioning. And so for those 3,400 buildings, it can be brutal in the summer, and there are measures talked about in this report and in the amendment and the motion I'm placing to improve them there. But imagine the shoulder seasons. Imagine in April, and this is an experience many of us have dealt with, where I recall last April being in a Chinese seniors home, a Toronto community housing building, where it was 32 degrees that day and the heat was on and the windows couldn't open because of child protection strategies. People were roasting. And so imagine that situation. And part of where we have an approach here is how do we have cooling spaces throughout the city? So there's the 180 spaces, and how do we have signage for them? That's important. Part of the conversation here is how do we have cooling rooms and shade structures? Those are all important. But then I want to take a step back to say, it's 3 in the morning, you're a senior, what are you going to do? You're not going to a cooling space, and you're not going to the school that is AC. And so that, I think, really helps to frame this conversation. So why are we here? We're here in part because this issue is so damn complicated in terms of who's in charge. You have Planning Act provisions, municipal code provisions related to window protection. You have licensing and standards involved in this related to enforcement and landlords. You have the City Planning Department, Toronto Public Health, the Strategic Communications Division around communicating it. Private landlords who often, when you reach out to say, hey, you can turn off the heat, they don't want to because it's going to cost money to turn off the heat and turn it back on. So a lot of people are involved. So how do we move forward? So the motion in front of you and some of the city's work, on the long term, we need to look at buildings in general, and whether it's air conditioning in buildings, and how do we ensure that through tower renewal they're improved. So new buildings and redeveloping buildings, we need to look long term at those. And there's part of the motion in front of you talks about the development application process and measures that city planning can look at there. That's in the long term. In the medium term, we need to look very clearly at tower renewal, and one of the pieces in the motion here is to request to look at a grant-based program to improve tower renewal, but also we need to look at window safety provisions. So that does the municipal code need to be changed to allow windows to be opened further without endangering safety? And we need to make sure as we think about these medium-term measures that we're providing heat relief, but we're also not dehousing people involuntarily, so that we're creating above guideline rent increases that end up dehousing the people we're trying to protect. But then there's the short term. And this is where I think we have a lot of work to do, ensuring that you have cool rooms, that we have this updated list of vulnerable tenants and outreach that Councillor Perks has spoken of, and it's included in the motion here around the 2020 budget, that we need to utilize the 180 spaces with AC in the city with increased signage, but also to look for other spaces like Sue Wong has talked about. But then really critically for this board in this season is to look at the shoulder seasons. That period between September 15th to June 1st, when too many landlords think that they have to have the heat on. They don't. So one of the items in the motion here is for that overarching citywide strategic communications plan. And how do we make sure that everybody is aware of it in terms as landlords, that they're aware they don't have to have the heat on, that we communicate to them. And so there is a call for a report back from the Medical Officer of Health in April on that. There's also in this motion to look at, do we need to review these dates? The former dates, do the dates of September 15th to June 1st, the heat guidelines, do we need to review those dates? Toronto Community Housing, the city is the shareholder. How do we make sure that Toronto Community Housing is following through on this to make sure that they know that they need to turn off the heat? All of those are some of our immediate short-term items. And so it's a complicated issue. As somebody who's only been at City Hall for 5 years and others who've been on this far longer than me, I've come to appreciate how tough this is, but fundamentally this is about adaptation and mitigation with climate change. It is a public health issue, and in this term, this is an issue that you have my commitment. We are going to be on again and again and again. It may be complicated. We need to work in concert with our staff, but we need to address it. And so with that, I'll conclude my remarks. I believe I was the last speaker, but I'll just do a go-around. Anybody else to speak? Cynthia Lai, Councillor Lai.
I'm sorry, I just want to quickly add that I'm very happy. I mean, this is the first year I sit on the Board of Health, and I don't even know this is one of the issues that we deal with in the city, and it's really eye-opening. I used to live in the condominium, and we always have property managers, you know, it's too hot or too cold or something, and nobody acted. I think, you know, just to add on the communication strategy, I think we should probably include those property managers association as well. You know, they need actually to know whether they, you know, they could be flexible as a, you know, as a very good mitigation measure for climate change. And I think it's a very good that I'm very happy that I'm actually sitting on this committee now, that we're addressing some really, you know, very practical issues. Thank you.
On behalf of all of us, we can say we're happy you're here too. So with that, any final speakers? Seeing none, we'll start by the motion that I had placed, which was done in coordination with Councillor Perks and Councillor Matlow. Let me move that. All those in favor? Opposed, if any? That carries. The item as amended. We don't need to. This replaces it. We don't need the item as amended. And so that passes. That is the last item on our agenda for today. Thank you for the patience to members of the board, as this is my first time sitting in the chair. And to new members of the board, welcome. And to returning members, thank you for being with us. That concludes our item. Thank you very much.